How you doing, EMT student? My name is Paul Bedell. I'm one of the adjunct faculty here at Pima Community College, East Campus. And I'm here today to present to you Chapter 8, Lifting and Moving Patients. So anytime during this lecture, if you have any questions, please take notes. That way you can present it and ask those questions for the first hour of class when you return to class. So I will start this presentation. I get to begin here. Oh. All right. So in the course of an event on a call, you're going to have to move patients either from some point from point A to point B. So from their bedroom to your stretcher, to this ambulance, to of course transferring that patient to a hospital bed. So there's going to be some lifting, moving, dragging at some point in your career on these calls. And to move a patient without injury to yourself, your partner, of course the patient, you need to learn the proper techniques. And I'm going to be discussing these techniques today, but you'll have some time to practice in class. Knowledge of proper body mechanics and proper grip are going to be very important. It's going to prevent the injuries to you, your partner, of course, the risk of injury to your patient, and any injury that you may have, of course, could be a career-ending injury. So one of the pieces of equipment, the wheeled stretcher, also called the gurney. This is a pretty common device going to be used out in the field. Not taken up and down stairs for obvious reasons, the size of the stretcher and the weight being 145 pounds to the max, and then you're going to be adding a patient's weight on top of that. So it's not very safe to go up and down stairs with that device. Some of the features of it is basically a strong metal frame. They're adjustable in height from as low as 12 inches off the ground to about as high as 36 inches off the ground. There's going to be some hinges to allowing the head to sit to a seated position, and of course lowering it back down flat, and even the feet can be raised up slightly. They'll have some guardrails on the sides, and these guardrails aren't really going to prevent somebody from completely falling off the stretcher, but it'll have some guide rails there that can give them some support. Of course, there'll be a mattress they're laying on. This mattress should be really easy to clean. There should be no real seams. Everything should be well sealed. So again, easy to decontaminate. And of course, there's going to be some straps so you can buckle the patient into that stretcher. And of course, there'll be wheels, and certain wheels will have locks on them so the stretcher won't roll around on it. So how about a backboard? Backboard, spine board, trauma boards, been called different things. But these are going to be used for patients either to transfer them from, again, point A to point B from, let's say, a vehicle accident, and you may have to just use it to slide them onto your stretcher without having to have them get up and walk, or they could be used to be secured to this device until you get them to the hospital. They'll have holes along the edges of these, and of course there'll be for handrail or handholds, and then you'll even see, even from the picture here, they'll have some little pins in there, and those will be for straps that have the quick connects to them also. So dealing with moving the patient, it should be done very orderly in a planned way, and it shouldn't be a rush. There may be some times where it needs to be rushed, but for the most part, take your time, have a plan, communicate with each other, you and your partner, and also communicate with the patient. When you move a patient, take care not to cause any injuries, of course, to you, yourself, and your partner, and of course the patient. The patient lifting and moving, technical skills that we're just discussing right now, but it will be open to practice when you get back to class. Using proper body mechanics, again, very important. Maintaining physical fitness is important. So starting now, if you haven't already, get on some type of exercise routine, figuring how you can work on your core, your back, legs, arms. Some cardio, of course, never hurts. But it's going to be all the fitness exercising that you do is going to reduce those injuries. So for proper mechanics, lifting position, the shoulder girdle should be aligned with the pelvic region. Hands should be, again, held close to the legs. Force then goes essentially straight down the spine, and very little strain should be occurring. If you're straining to do this, you need to be asking for help. Here's an example of what improper technique would look like. If you're lifting while leaning forward, of course, that's not proper technique. And even if you lift with your back straight, but bent significantly forward at the hips, Again, improper technique. I would hope you and your partner are looking out for each other. If you notice something that doesn't look right, you'd speak up so you can prevent those injuries. Now, there might be some situations where the patient may be in some type of confined space or wedged somewhere in some location that it may require a little bit of more effort to get in a position to be able to move that patient enough so you can use proper body mechanics to finally finish the move. Be aware of that. So again, in proper lifting technique, the legs should be spread apart, about 15 inches, shoulder width apart, placing the feet so that the center of gravity is balanced. You don't want to be off balance in any way. With your back held upright, bringing the upper body down by bending at the legs, basically a squatting position, and grasping the patient or stretcher to be able to get ready to lift up. So lifting the patient by raising the upper body and arms and straightening your legs. Again, that kind of a squat technique, and then that power lift. And that power lift is simply lifting by extending the proper placed flexed legs is the safest and most powerful way to do this. Again, just thinking of it as if you work out at the gym or at home even, and you're doing some type of squat exercises, that same idea, but now you need to start adding that weight. Keeping the weight close to the body as possible is very key. And then keeping the arms about the same direction or same distance apart would be ideal so you're not off balance. So how about the power grip? Well, this is going to be the grip that gets the maximum force from your hands. So in comparison to this type of grip, compared to this type of grip, big difference. So having the palms up, hands about 10 inches apart, all the fingers, including the thumb, at the same angle. And then you're going to place that handle on the palm of your hand so it won't fall through. This way you have an easier chance of it actually falling through. Then direct the lift, tightly grip the patient or the device in a place and manner that will ensure that you don't let it go. Nothing worse than dropping the patient, causing injury, real bad PR. How about a body drag? Again, keeping the back locked, straight by tightening the abdominal muscle, those core muscles. Kneel and extend your arms no more than 15 to 20 inches in front of you, because again, you're asking for that risk of injury. And then alternate between pulling the patient by flexing your arms and repositioning yourself. Don't be afraid to do it in short burst moves until you get them in a position where you have more room to do a proper lift or drag. So how about dragging the patient across the bed? Kneeling on the bed to avoid reaching beyond the recommended distance. So if it's a large king-size bed and they're in the middle of it and you may have to kneel on one side to get closer enough to the patient, or again, bunching up the sheet next to the patient. And then as you start pulling towards yourself, you will eventually be able to stand next to the bed and continue to finish the move. So again, completing the drag while standing at the side of the bed, using the sheet, blanket, maybe the patient has some bulky clothing on that you can use to continue that drag. Again, once you get them to the point of the stretcher, that stretcher will have to be, again, put in place that you and your partner can then go from that bed position to that stretcher, either via a board or, again, directly to the stretcher. So now let's say you've made it to the hospital, and now you got to get the patient off your stretcher. So once you do this, you want to make sure the stretcher should be the same height as the hospital bed. That would be ideal. Sometimes hospitals will have basically a thin plastic device that you can slide the patient onto, just being careful that that does cause some static charge. And you and your partner, again, should kneel on the bed as the drag starts moving in increments so you're not overextending your arms. Now, again, those will be practiced a little more in class. We do have means of practicing those type of drags and moves. So how about log rolling? So we want to use a board device because maybe we have a spinal concern and we want to make sure we get this patient rolled over, cleared their back, and put on a board. So log rolling the patient onto their side, depending on if there's an injured side of the patient, non-injured side of the patient, you want to choose the side that you're going to log roll on. The person at the head is usually in charge of the controlling of the rolling, counting, of course, 1, 2, 3, roll. And then as you keep them in line, neutral position, you want to make sure you roll that patient, again, all at once, having the board slid next to the patient, making sure you don't let go of the larger part of the patient, being that torso part of the patient. So make sure someone at the waist or legs can scoot the board up closer to you. And then you have an option of just leaving the board flat, like in the picture there. Or some people tend to raise the board up on some slight an angle, basically, to get the patient onto the board. Either way, you want to make sure you keep them in line, neutral position, get the board up close, and then the count of 3, roll them back down onto the board after you've cleared their back. Once on the board, of course, you don't see any straps in the picture here, but make sure you do strap the patient to that board before you move them from that point A to another point B. Okay, continuing on with log rolling, kneel as close to the patient as possible so we're not outreaching too far. Keeping the back straight and lean solely from the hips. Rolling the patient without stopping. So one fluid motion, 1, 2, 3, roll on their side. Again, hopefully the uninjured side. As you're doing it in one fluid motion, making sure that you're bracing the patient up against your thighs so they don't continue to roll over toward a prone position. And then pulling toward you allows your legs to prevent the patient from, again, rolling over completely. Another thing you want to make sure is communicating with the patient that you're doing this type of roll, making sure you're doing all the work for the patient so they don't try to move for you and compromise that spine. So again, whenever possible, use a device that can be rolled to move a patient. So something with wheels. When a wheeled device isn't available, for whatever reason it may be, make sure you understand the following guidelines for carrying a patient on a stretcher. So the patient's weight has got to be a consideration. In some cases, you may have to ask the patient, how much do you weigh? Maybe you can just guesstimate by the size of the patient. So do not attempt to lift a patient who weighs more than 250 pounds with fewer than 4 providers. You'll have one at the head, one at the feet, those usually being the stronger of the providers that are there, and then another 2 on each side of the patient. So knowing the weight limits of the equipment, in addition to that patient, of course, and how to handle patients who exceed those weight limits. If you have to call for a bariatric ambulance to show up, they may have specialized equipment for that. So how about lifting and carrying that patient again without the use of wheels? Here's a technique here where you're more than of the patient's weight rests the head. So we know that upper body in our bodies is going to weigh significantly more than the lower half of our bodies. So again, the head and feet position should have the strongest personnel when you're doing this diamond type technique or even the one-handed carry. And then you'll have the other individuals on either side. You can have law enforcement help you out, other firefighters, EMS providers, possibly even some family or friends or coworkers that may be there. Whatever you have available to you to help you lift that patient and move that patient to an awaiting gurney or stretcher. So how about rolling a wheeled stretcher? Well, making sure that it's fully elevated position. If you have a bariatric stretcher that we'll show later on here, they'll have extended handles, so the stretcher can technically stay lower to the ground. But making sure the terrain that you're on, is it going to be on concrete, tile floor, or is it going to be in dirt, mud? Know the terrain you're on and be prepared for that because that may cause some complications while rolling that stretcher. And again, you and your partner should control the head end and assist you by pushing with his or her arms held with the elbows bent. So stay in that constant control, keep good grip strength as you're wheeling that stretch around. Most cases, you're going to be on some solid surfaces, so it shouldn't be too much of a problem. But anytime you make turns or there's a slope or a hill or some, again, loose gravel, be prepared for that. So what happens if you do have stairs, apartment complexes, hotels, whatever it may be, and you have stairs to contend with because for some reason there's not an elevator or the elevator's out of service? So again, you have to be able to do that with a stair chair. Now, this particular picture here has the tread type, I will call like tank treads at the back end of that stretch or that wheeled stretcher, that stair chair. And those are intended to slow the progress as you push the patient down the stairs. You literally be able to push them down the stairs and those will add added grip and it will actually prevent it from just rolling freely down the stairs. So it gives it some more support there. Lightweight, wheeled, of course, they'll foldable, so they'll collapse and be able to be stored in an ambulance. There's handles, of course, at the head end and at the feet end, as you can see from the picture there. Of course, there's some seat belts, molded seats, wheels with locks. So again, fairly similar to the lying supine style of stretcher or gurney. This one is just ideal for stairs. So moving a patient on the stairs with a stretcher, how about a backboard should be used, right? If the patient's unconscious and responsive, you're suspicious of a spinal injury, you want to make sure that you use that backboard. Once you're putting them on the backboard, using the proper log roll, of course, you want to make sure you secure them to that board. Carrying the patient on the backboard down the stairs to the prepared stretcher, making sure you're going down feet first And again, now that weight is being distributed differently, so be prepared for that. Again, I said earlier, how the stronger of the EMTs, head and feet position would be ideal. Even as you're going downstairs, the taller person would have a benefit of being at the feet because of how you're manipulating the patient going down the stairs. May not have any stairs in class to be able to practice this too much, but hopefully that made some sense. And if not, ask your instructor. So again, loading a wheeled stretcher into the ambulance. We do have some ambulances there on campus that we can practice loading and unloading a patient into the ambulance. So that's going to be a very big benefit. So ensure again that the frame is held firmly between the two hands so it does not tip. And again, some of the newer models will have battery powered, air powered. They'll even have in some bariatric units where the ambulance itself can be lowered down to the ground with either hydraulics or pneumatics. They even have some type of a winch or pulley system inside the ambulance. So as you're hooking up to the stretcher with the patient, you can flip a switch and it'll start hoisting basically the stretcher inside the ambulance. Others, you'll still have to lower the patient down low, and then you may have to, with the patient or your partner on either side, you'll have to do the 1, 2, 3 lift, and then eventually place it inside the ambulance. Others, you'll be able to just lock the front. There's like a couple of extra wheels at the front or head end of that stretcher, and it'll hook on a small hook, and then you'll be able to release the locking mechanism at the foot end as your partner raises the legs now to you, the bottom of the stretcher, and then you can, with some effort, push the stretcher into the ambulance until it meets the antlers, or basically these clamps that are inside the front of the ambulance, to be able to lock it in place. Be aware if the ambulance is not parked in a flat, level area, and you just think you can just push the stretcher in with the patient on it, it obviously may go, left or right. It may go toward the front. It just depends on the position of your ambulance. So always have somebody inside also, if that's a possibility, to help guide the stretcher into that locking mechanism. All right, directions and commands. So again, we kind of talked about this, but the person at the head should be in command, calling out the orders. Hey, on the count of 3, we're going to roll, lift, whatever. That team leader again indicates where each team member needs to be. I want you at this end. I want you on that side. Telling the patient again what to do. Rapidly describes the sequences of steps. We're going to go from in between the toilet and tub where the patient is, and just drag them out a little bit so we have a better access to the patient. So now we can complete a full drag or lift out of the bathroom. Preparatory commands and countdowns, like I've already said. So how about emergency moves? This is going to be used when there's a potential of danger and before an assessment or care can be provided for that patient. Fire, explosion, hazardous materials, whatever it may be, you need to gain access to that patient now. Use when you cannot properly assess the patient or provide immediate care because of the location, position of that patient. So again, vehicular type situations, confined space type situations, active shooter type situations, fire, explosions, whatever it may be, calling the appropriate trained PPE'd people to arrive and assist with this type of situation. So again, use techniques to help prevent aggravation of a patient's spinal injury, not just aggravating the injury, but how about aggravating the patient themselves? There may be a need for a clothes drag, you're grabbing their clothing, a blanket drag, it would be helpful if they were on a blanket, an arm drag, just by grabbing each wrist, and then arm-to-arm drag. And here's an example with those pictures showing you that. And then for lastly, with emergency moves, removing an unconscious patient from a vehicle. So can you even open the door? Is there damage to the vehicle? Are you properly PPE'd and trained to do this? So just be aware if it was, the door was easily accessible, the patient was just unconscious. Please remember, once you've opened that door, realize communicating with the patient, tell them not to move their head if they're awake. But if they are unconscious, scoot the seat back, raise up, tilt up the steering wheel if it has that ability to do so, but give yourself some more room. Then as you grasp them under their arms, just like that arm-to-arm drag was, grasp them under the arms, kind of rotating them again so their back is towards your chest, grasp them firmly, and as you turn and rotate and start to go out of the vehicle, make sure their legs are clear from the pedals. You don't want them getting caught up. So urgent moves. Necessary to move patients with an altered level of consciousness. So again, they may not be completely unconscious, but there's some altered level of consciousness here. They're not breathing well. They're not able to maintain their own breathing. They may even be in shock. So this rapid extrication technique should be used only if the urgency is there and exists. The vehicle or the scene itself is just not safe. There's some explosive hazards, fires. We've talked about that earlier. The patient can't be properly assessed prior to removing from that vehicle. They need immediate intervention that requires a supine position because you can't do CPR in a seated position. They have a life-threatening condition that requires immediate transport. Or they may be basically in the way of someone who does need your help. So rapid extrication increases the risk of damage if the patient has a spinal injury, risk of you injuring yourself, of course, and your partner also. Consider all your options before using that technique. Again, used when both the scene and the patient are stable for non-urgent moves now, okay? So if everything is safe, they're stable, we're gonna do some, get a plan going here, talk with the patient, can you do some of the moving yourself, okay? Plan it out, then do the move. There could be a direct ground lift. Hey, I don't want you to have to get up yourself. Let us go ahead and lift you from the ground, okay? For supine patients with no suspected spinal injury, you can do the direct ground lift. Patients who need to be carried over some distance, direct ground lift. And EMTs stand side by side to lift, carry that patient, still using good communication, good technique. How about an extremity lift for patients with no suspected spinal injury, patients who are in a small space, and one EMT at the patient's head, the other one's at the feet, still proper technique, making sure as you're walking also, you're both going in that same direction, so no one has to walk backwards. Transfer moves, the direct carry. We've talked about these basically already, but the direct carry, moving a supine patient from the bed to the stretcher, the draw sheet method, using the sheet that they're on, of course, the scoop stretcher, haven't mentioned that one yet. We'll show you a picture in a little bit, but inserting the two halves of the scoop stretcher under each side of the patient, and like that claw type of game with the little toys you can pick up, right? You're doing that same concept. You're doing the claw technique around the patient, lifting them up, moving them onto another device. Log roll or slide to move the patient onto a backboard, secure the patient and lift and carry backboard to a nearby awaiting stretcher. Assist patient to the edge of the bed. So here's a different technique. They're in bed, they're able to move, right? Hey, scoot over to the edge there. Place the patient's legs over the side of the bed. Help the patient sit up. Maybe you have to grab them from the shoulders or something. Kind of sit up, 1, 2, 3. Now as they're sitting up, move the stretcher so that the foot end touches the bed near the patient. Help the patient now stand up. Maybe I'll just grab them by the shoulders, grab them by the waist belt. Maybe they have a gait belt or something that they're wearing because they're lift assist. But again, help them stand up and then rotate so that they can sit on the center of the stretcher. Lift the patient's legs and then rotate them onto the stretcher while you and your partner lower the patient's torso onto that stretcher. You may want to leave them in that seated position, whatever the position of comfort will be. How about geriatrics? Many patients transported by EMS are going to be geriatric patients. They have some brittle bone disease, some rigidity, spinal curvatures, and there'll be a picture of that here. They may present with some special challenges. Consider the use of specific devices for these type of patients, maybe even a vacuum mattress. So again, if you have padding, you can maybe put the patient maybe on their side, if that's more comfortable for them. Position of comfort is ideal. If you use a vacuum mattress, just realize this is going to be a device that draws the air out and it starts to conform around the curvatures of the patient's spine. Making sure you put at ease the patient's fears. Have some sympathy, have some empathy for this patient. Understand what they're going through because you yourself have practiced this and been a patient, simulated patient yourself in class. There's the examples of some of the curvatures of the spine. Now we've talked already a little bit about some bariatric, but again, what about the bariatric patients? This is dealing with obesity. Back injuries account for the largest number of missed days at work. So again, dealing with the company side of things, dealing with workman's comp issues, they want to make sure those companies are trying to prevent these types of injuries. So they want to give you the special devices to hopefully alleviate this type of stress. Stretchers and equipment are being produced with higher capacities. They could even handle 800, 900 pound patients, but just realize there's still a certain width of stretcher because you still have to be able to fit it through the back doors of your ambulance. So those guide rails that we talked about where you lock them in place, they may not be able to go up because of the size of the patient. So Example of a bariatric stretcher, specialized overweight obese patients. I already mentioned how lower they can stay with those elevated handles, and there again being the weight rating for it. Mentioned a little bit about pneumatic or electric powered wheel stretchers. Again, these are adding weight to these stretchers. So we mentioned about 145-pound max for just the stretcher itself. This would be increased for that. If the batteries do go bad or something does fail, now you're lifting that in the back of your ambulance with the weight of a patient, and that adds to that weight. So be prepared for that if that does fail in some capacity. So always keeping it checked, charged, know your equipment every day before you start your shift. How about a folding cot type stretcher? Pretty easy to store, very thin, fold up, of course. There's no wheels. It's strictly just for moving a patient from point A to point B over some type of distance. Fairly strong, lightweight, of course, aluminum type construction. And then again, they're just used to transfer from point A to point B to that awaiting ambulance. Now for some of the technical rescue sides, we won't be practicing this in class, but they have some type of sked boards, they're called this type of device. And it's just a flexible stretcher that kind of conforms around the patient. And again, their patient being inside that, they're completely secured. There should be no way they should fall out of this. And then they can be lowered or hoisted up, depending on the situation where the patient was found. They can also be slid along a certain distance if it was more like a confined space type area. But again, we won't be practicing this in class, but be aware this type of equipment does exist. So how about a half board, short board, KED board? These are type of devices for the seated patients that are complaining of spinal injuries. Maybe you don't have any more spine boards on scene because you had a mass casualty event. This piece of equipment could be very useful for that. And as I mentioned earlier about the vacuum mattress, again, this could be an opportunity to use instead of a spine board or a backboard. It does have basically pleats in it with wood paneling in there to give it some rigidity to it. And it does really good for conforming to the curvature, so there's no need for padding any voids, because this vacuum, the mattress will basically fill into those voids as the air is being drawn out of it. The basket or Stokes stretcher, it's a rigid litter. Again, more of a rural type interface where you might run across a patient, search and rescue type scenarios. You can still either put the patient onto a board and then into this basket. They can still be hoisted up. There's points of contact where you can do some technical rescue, helicopter type of evolutions, or they may even have a large type of bicycle tire underneath, just one single tire. So you can wheel them over, rough terrain until you get to a big clear opening where the helicopter can then transfer that patient from there to the awaiting parking lot where the ambulance might be, for example. In case of spinal injury, secure the patient to the backboard again, and then secure inside the basket. So they'll have straps inside there, especially if you're going up and down all around with that patient, making sure they are truly secured. And once you get them to the ambulance, you want to make sure you take them out of this basket-type stretcher, and then you can set that basket or Stokes stretcher back to the agency that it came from, and then you'll be able to transport your patient. There's your picture of your scoop stretcher that we talked about earlier. It's basically splits into 2 to 4 pieces. You basically pull the pins, it releases it, allows it to open or deploy, and then it scoops under and around the patient on either side, and then it locks back in place. And then count of 3, 1, 2, 3, you lift. This is quite nice when it comes a lot of dirt, debris, so it tends to want to fall through, so you're not taking all that with you and the patient. Here's a specialized piece of equipment here, a needle nail isolate. So again, I think of it as more of like an incubator type thing, but it's basically a crib for these babies, and it keeps them warm, protected. Noise, draft, infection, excessive handling, so they'll be using some plastic around it. So it's really, really specific for them when they're still fighting for their life, if they're in a NIC ICU type of example. Again, these can be secured to a wheeled ambulance. If you're doing it in a facility transport, possibly, there may be a nurse with this type of patient, or they can be just freestanding like in a hospital setting. Gosh, we got to clean our equipment, right? After every patient contact, maybe even at the end of a shift or prior to you starting your shift, you may want to go through and check your equipment and clean it. But it's going to be important to follow the proper guidelines and SOPs for decontamination and cleaning your equipment. If it's not cleanable, if If it's disposable, then by all means, get rid of it. So decontamination is going to be for our safety, the crew's safety, of course, patient safety. We don't want to be spreading the disease. Knowing and following your proper protocols and standards is going to be very important. You'll have some training on this. We'll be doing it in class, cleaning our equipment after every use. Even though we're using fake blood, it's a good habit to get into. Clean your equipment after every use. And then how about patient positioning? So proper positioning is going to be based on the chief complaint. Should they be unconscious and responsive? Lie them flat. Are they complaining of respiratory problems? Sit them up. How about just asking them? You want to sit sitting up or lay down? What makes you more comfortable? If they have abdominal problems, they want to sit on a side, knees drawn to the chest, like fetal position, whatever works. So shock position again, lowering their head flat, raise the feet of the stretcher, right? As long as they don't have any internal, injuries from the head all the way down to the groin, that would cause some further complications if you raise their feet, so be aware of that. And then patients with late stages of pregnancy, they should be positioned on their left side. We'll talk about that in future chapters, but that's still a very important technique to consider. And then an unresponsive patient, right? No suspected spinal injury, they should be put in a recovery position. Why don't they feel like they're gonna vomit? Why don't they are conscious and they tell you they're gonna get sick and throw up? Get ready with that emesis container to be able to allow them to vomit in an appropriate receptacle. And if they are strapped to that device, don't be afraid to unbuckle them so they can sit up and roll over so they can throw up. You don't want a patient aspirating on something. Now, if they're unconscious, of course, and they do start to throw up, you want to get suctioning ready. And again, we'll talk about that in a later chapter. Medical restraints. So there may be an unfortunate situation where you have to restrain the person. They want to cause harm to themselves or to others. They may be combative, head injury. It could be an oxygen issue. It's a sugar issue. So it would be helpful if we try to rule out what this cause was, assess the patient. But if we're not able to treat and correct this, we may have to restrain the patient. Following proper protocols, it takes 5 people to do this appropriately, 1 at the head, 1 at every extremity. There should be law enforcement involved, okay, making sure you get the name of the officer and their badge number once they arrive. And then restrain the patient in that supine position. Hands can be up in an elevated position, making sure you're communicating with the patient that you're doing this, and making sure that it is justified. You're gonna have to document this. Why did you do this? Nothing worse than you showing up to the hospital with an extremely calm 90-year-old lady that is 100 pounds wet and she's restrained, and you're gonna have some questions to answer. So justify why you restrained that patient. There also is that risk of positional asphyxia, especially if the patient's in a prone position. So be aware of that. Try to restrain them, of course. Practically would be, and safety would be in that supine position ideally. Okay, each extremity, I already mentioned that. Monitoring their ABCs and their mental status, looking out for changes, constantly monitoring the patient every 5 minutes. And document, 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 document. I believe the last slide here, talking about questions to ask before moving a patient. Maybe to yourself, you can even possibly ask your partner if it's a new partner maybe, but am I physically strong enough to be able to lift and move this patient? That's why I don't mind you telling it to your partner. Hey partner, are you sure you're good for that? Maybe you had a recent injury that I know about. Are you sure you're good to go? Is there adequate room? Maybe they're stuck again between that toilet and tub type concept, confined space, whatever it is. But do we have the room to do this? Do I need additional help? Hey, ask for the help. An injured EMT cannot help anyone. It can even end your career. So please ask for help, proper training, get that workout routine going, okay? And all the practice we're gonna do in class is still not gonna feel like enough. You gotta continue to practice these type of skills because again, you don't want an injury to your back, please. Again, that's all I have. You have access to this PowerPoint also. There's review questions at the end of every PowerPoint that we have. Take the time, go through those review questions. If you had questions about this information that I covered, please jot all that down and bring it to class. And then the first hour of class, we'll be discussing the questions, basically like a Q&A type thing. We may even go over the review questions possibly. So please take notes and bring to class questions. And thank you so much for your time.